Hello and welcome to the Emergency Room Podcast, the place where we delve into the fast-paced, life-saving world of emergency medicine. Are you ready to explore the critical decisions and cutting-edge treatments that happen daily in the ER?
All right, so picture this. You're in the ER and a patient comes in with just agonizing abdominal pain.
Oh, yeah.
It's sudden, intense, radiating to their back. Their labs show just sky-high levels of digestive enzymes. What's going on? Well, you're about to dive deep into the world of acute pancreatitis.
That's right.
We've got a stack of research here ready to break it all down.
Awesome.
We'll cover everything from the classic signs and symptoms to the cutting-edge research that's shaping the future of how we diagnose and treat this condition.
Yeah, we're going to equip you with the knowledge to recognize, understand, and manage this challenging condition, whether you're a seasoned healthcare professional or simply someone who wants to be well-informed about their health.
If you are a healthcare professional, especially those of you on the front lines in emergency medicine, make sure to subscribe to Emergency Room Podcast for more in-depth discussions on critical care topics.
Yes, definitely.
Now let's start with the basics. What exactly is acute pancreatitis?
So acute pancreatitis is an inflammatory disease of the pancreas, that organ tucked behind the stomach that plays such a crucial role in digestion and blood sugar regulation.
Right.
And it can range from mild, with inflammation and swelling to severe with tissue death and even life-threatening complications.
Okay, so this inflammation can be pretty serious.
It can be.
Why is acute pancreatitis becoming more common? What's behind this global rise we're seeing?
Now, it's a complex interplay of factors, but some key contributors are the increasing prevalence of gallstones, rising rates of alcohol abuse, and even our changing dietary habits with the increase in high-fat diets leading to hypertriglyceridemia.
So we've got these lifestyle factors playing a role.
Yeah.
What are the most common culprits we see triggering this inflammation?
So gallstones and alcohol abuse are the classic triggers,
Okay.
accounting for a significant percentage of cases.
Right.
Think of gallstones like little pebbles that can get lodged in the bile duct,
Right.
obstructing the flow of digestive enzymes from the pancreas, and that backup can lead to inflammation. Alcohol, on the other hand, can directly damage pancreatic cells, triggering that inflammatory cascade.
This is like a double whammy.
Yeah.
Are there other causes besides those two?
Absolutely. High levels of triglycerides in the blood, known as hypertriglyceridemia, can also be a culprit.
Okay.
Then there are certain medications, infections, genetic predispositions, and even anatomical abnormalities in the pancreas that can contribute to acute pancreatitis.
Wow.
In some cases, we never pinpoint the exact cause, and those are classified as idiopathic pancreatitis.
So it's like a medical detective story, sometimes trying to track down the root of the problem.
It really is.
You mentioned that acute pancreatitis can range in severity.
Yes.
How do those different levels of severity actually manifest in the pancreas? What's happening on a microscopic level?
So in milder cases, we see interstitial edematous pancreatitis, where the pancreas becomes inflamed and swollen, kind of like a sprained ankle.
Okay.
But in more severe cases, we see necrotizing pancreatitis, where parts of the pancreas actually start to die.
Oh, wow.
This necrosis or tissue death is what can lead to more serious complications.
That sounds pretty scary. What kind of complications are we talking about?
So both types of acute pancreatitis can lead to fluid buildup around the pancreas. These are called acute peripancreatic fluid collections. Think of it as your body trying to contain the damage by walling off the inflammation with fluid.
Right.
The problem is that these collections can sometimes get infected, leading to a condition called infected pancreatic necrosis, which can be life-threatening.
So these fluid collections are like a ticking time bomb in some cases.
They can be.
How do doctors determine if someone has acute pancreatitis? What are those red flags you're looking for in the ER?
So we look for the classic triad: sudden severe abdominal pain, typically in the upper abdomen and often radiating to the back.
Okay.
Elevated levels of pancreatic enzymes in the blood, specifically amylase and lipase. And characteristic findings on imaging studies, usually a CT scan.
Let's break those down a bit. You said that pain is usually the first sign. What kind of pain are we talking about?
It's typically described as a sharp, stabbing pain that can be so intense it makes you double over.
Oh, wow.
And the location is key. Upper abdomen, often radiating to the back. That radiation to the back is a big clue that the pancreas might be involved.
So if someone comes in with that kind of pain, you immediately think pancreas.
It definitely raises a red flag.
Yeah.
We then order blood tests to measure levels of pancreatic enzymes, specifically amylase and lipase.
Okay.
These enzymes are normally found in the pancreas, helping with digestion.
Right.
But when the pancreas is inflamed, they spill into the bloodstream.
And you mentioned that we're looking for significantly elevated levels. What's considered significantly elevated?
We typically consider levels that are 3 times the upper limit of normal to be significant for acute pancreatitis.
Okay.
But it's important to remember that these tests aren't perfect. Other conditions can also cause elevations in amylase and lipase, so we can't rely on them alone to make the diagnosis.
So what else do you look for besides pain and elevated enzymes? You mentioned imaging studies.
Right. Imaging is crucial for confirming the diagnosis and determining the severity of the pancreatitis.
Okay.
The gold standard is a contrast-enhanced CT scan, which gives us detailed pictures of the pancreas and surrounding structures.
Right.
We can see the extent of the inflammation, identify any fluid collections, and look for signs of necrosis.
So the CT scan helps you paint a complete picture of what's going on inside the abdomen.
Exactly. It's like having a roadmap that guides our treatment decisions.
Now, I've heard that there are newer, more sophisticated tools being developed for diagnosing acute pancreatitis. What are those?
That's right. Researchers are looking into biomarkers, which are specific molecules in the blood that can signal the presence and severity of pancreatitis.
Okay.
Some of these biomarkers are showing promise in early studies, potentially offering even more accurate and faster diagnosis than our current methods. There's also growing interest in using artificial intelligence to analyze CT scans and predict the severity of pancreatitis.
So technology is really starting to play a role in how we diagnose and manage this condition.
Absolutely. It's an exciting time to be in medicine. We're constantly refining our tools and techniques to provide the best possible care for our patients.
Okay, so we've covered a lot of ground here, from the underlying causes and types of acute pancreatitis to the key steps in diagnosis.
We have.
But what happens next? How do doctors actually treat this condition?
Well, like we've discussed, acute pancreatitis can range from mild to severe.
Right.
So the treatment approach has to be tailored to the individual patient.
So there's no one-size-fits-all solution.
Exactly. But regardless of the severity, there are some fundamental principles that apply to all cases.
What are those foundational steps that are taken for all patients with acute pancreatitis?
First and foremost, we focus on supportive care.
Okay.
This means making sure the patient is well hydrated with intravenous fluids, managing their pain, and providing nutritional support.
Why are fluids so important in acute pancreatitis?
When the pancreas is inflamed, it releases inflammatory mediators that can cause fluid to leak out of blood vessels and into the surrounding tissues. This can lead to dehydration and a drop in blood pressure, which can be dangerous.
So IV fluids are like a lifeline for these patients.
Exactly. We need to replace those lost fluids and keep the patient's blood pressure stable.
And what about pain management? You mentioned that pain in acute pancreatitis can be quite severe.
Pain control is absolutely essential. We typically use intravenous pain medications, often opioids, to manage the pain effectively.
Right.
We need to prioritize the patient's comfort so they can focus on healing.
It sounds like you're really taking a holistic approach, addressing not just the physical symptoms, but also the patient's overall well-being.
That's right. We want to provide comprehensive care that addresses all aspects of the condition. And another important part of that is nutritional support.
I'm curious about the nutritional aspect.
Yeah.
Years ago, the standard practice was to keep patients with acute pancreatitis on a nil-by-mouth regimen, basically not letting them eat anything.
Yeah.
What's the current thinking on that?
We've learned a lot in recent years, and that approach has evolved significantly.
Okay.
The old thinking was that resting the pancreas by withholding food would help it heal, but now we know that early feeding is actually beneficial.
Why the change in thinking? What are the benefits of early feeding in acute pancreatitis?
Early feeding helps to preserve the gut barrier,
Okay.
which prevents bacteria from leaking into the bloodstream and causing infections. It also helps to support the immune system and promote healing.
So it's not just about providing calories, it's about supporting the body's natural defenses and healing processes.
Exactly. If the patient can tolerate it, we encourage them to start eating as soon as possible. If oral intake isn't feasible, we can provide nutrition through a feeding tube.
So you have options to ensure the patient gets the nutrients they need, regardless of their ability to eat. Now, in addition to these foundational measures, do you tailor the treatment based on the specific cause of the acute pancreatitis?
Absolutely. If gallstones are the culprit, we often recommend a cholecystectomy,
Okay.
which is the surgical removal of the gallbladder. This is usually done after the initial inflammation subsides, but during the same hospital stay for mild cases.
So you're basically eliminating the source of the problem to prevent future attacks.
Precisely. And if hypertriglyceridemia is the trigger, we focus on lowering those triglyceride levels through medications and dietary changes.
So it sounds like a multidisciplinary approach is key, involving not just gastroenterologists, but also potentially surgeons, nutritionists, and others.
You got it. Managing acute pancreatitis effectively requires a team effort. And we also need to be vigilant about those potential complications we discussed earlier, like infected pancreatic necrosis.
You mentioned that infected pancreatic necrosis can be a life-threatening complication. How do you manage that?
It requires prompt and aggressive treatment, often with intravenous antibiotics and drainage procedures to remove the infected fluid.
What are those drainage procedures like? Are they major surgeries?
We try to avoid major surgery if possible.
Okay.
We often use minimally invasive techniques guided by imaging to drain the infected fluid collections. This can be done through the skin, called percutaneous drainage, or through an endoscope, which is a flexible tube inserted through the mouth or nose.
So you're opting for less invasive approaches whenever possible.
Exactly. Minimally invasive techniques generally lead to faster recovery and fewer complications. But in some cases, surgery might be necessary to remove infected tissue.
So it's a step-up approach, starting with the least invasive options and escalating if needed.
That's right. We always strive to tailor the treatment to the individual patient's needs and the severity of their condition.
It sounds like managing acute pancreatitis is a bit like a balancing act, weighing the risks and benefits of different treatment options.
That's a great way to put it. We're constantly assessing the patient's condition, looking for those subtle clues that tell us whether to stay the course or adjust our approach.
So it's a dynamic process constantly evolving as the patient's condition changes. Now let's shift gears a bit and talk about the long-term implications of acute pancreatitis.
Okay.
We focus on the immediate management, but what are the potential consequences down the road?
One of the key concerns is the risk of recurrent episodes of acute pancreatitis.
Okay.
Each bout of inflammation can cause more damage to the pancreas, increasing the likelihood of developing chronic pancreatitis.
And chronic pancreatitis is a whole other ballgame, right?
It is. Chronic pancreatitis is characterized by persistent inflammation and scarring of the pancreas, leading to chronic pain, digestive problems, and an increased risk of pancreatic cancer.
So preventing those recurrent episodes is crucial. What can patients do to lower their risk?
Lifestyle modifications are essential. Avoiding alcohol is paramount.
Right.
For those with gallstone pancreatitis, maintaining a healthy weight and eating a balanced diet low in saturated fats can reduce the risk of gallstone formation. And for those with hypertriglyceridemia, dietary changes and medication to lower triglyceride levels are key.
So it's about empowering patients to take control of their health and reduce their risk factors.
Right.
Now let's circle back to the diagnostic process. You mentioned earlier that imaging plays a crucial role. Can you walk us through the different imaging modalities used in acute pancreatitis?
Sure. The first-line imaging test is often a transabdominal ultrasound.
Okay.
It's non-invasive, relatively quick, and readily available in most emergency departments. Ultrasound can help us visualize the pancreas, look for gallstones, and detect fluid collections.
So it gives you a quick initial assessment. But what are the limitations of ultrasound?
Ultrasound can be limited by factors like bowel gas or obesity, which can obscure the view of the pancreas.
Okay.
In those cases, we often turn to a contrast-enhanced CT scan.
And you mentioned earlier that the CT scan is considered the gold standard. Why is that?
A CT scan provides much more detailed images of the pancreas and surrounding structures.
Right.
It allows us to accurately assess the extent of inflammation, identify areas of necrosis, and pinpoint fluid collections with precision.
So the CT scan gives you a more comprehensive picture. Are there any other imaging modalities you use in acute pancreatitis?
Magnetic resonance imaging, or MRI, can also be helpful in certain situations.
Okay.
It's particularly useful for evaluating the pancreatic duct and characterizing the nature of fluid collections. MRI can help differentiate between simple fluid collections and those that contain solid debris, which can guide treatment decisions.
So you have a toolbox of imaging modalities, each with its strengths and limitations. You choose the best tool for the job based on the individual patient and their clinical presentation.
Exactly. It's about tailoring the diagnostic workup to get the most accurate and informative picture of the situation.
Now, you also mentioned scoring systems earlier, like the Ranson criteria and a Pitch 82.
Yes.
What are these scoring systems, and how are they used in the management of acute pancreatitis?
Scoring systems help us predict the severity of acute pancreatitis and the likelihood of complications.
Okay.
They take into account various clinical and laboratory parameters to assign a score which correlates with the patient's patient's risk.
So it's like a risk stratification tool. A higher score means a higher risk of complications.
That's right. The ransom criteria, for example, use 11 factors assessed at admission, and 48 hours later, things like age, white blood cell count, blood glucose, and levels of certain liver enzymes. The APT-2 score is a more general severity of illness score that looks at various physiological parameters.
Okay. You also mentioned the BISAP score, which stands for Bedside Index for Severity in Acute Pancreatitis. What makes that one different?
The BISAP score is designed to be a simpler, more readily available tool that can be used at the bedside to quickly assess severity. It uses 5 easily obtainable variables: blood urea, nitrogen, impaired mental status signs of systemic inflammatory response syndrome, age over 60, and the presence of pleural effusion.
So it's a quick and dirty way to get a sense of how sick the patient is.
Yes, and it's surprisingly accurate. A BISAP score of 3 or greater is associated with a significantly higher risk of complications.
Now, are there any newer, more sophisticated scoring systems on the horizon?
Researchers are exploring the use of machine learning algorithms to predict the severity of acute pancreatitis.
Oh, wow.
These algorithms can analyze vast amounts of data from electronic health records, including demographics, lab values, imaging findings, and even genetic information.
So these algorithms are like super-powered calculators that can sift through mountains of data and identify patterns we might miss.
Exactly. Early studies suggest that these machine learning models may be even more accurate than traditional scoring systems.
It sounds like artificial intelligence is poised to revolutionize how we approach acute pancreatitis from diagnosis to treatment.
It's an exciting frontier with the potential to personalize care and improve outcomes for patients.
Okay, so we've covered a lot of ground on the diagnostic front. Now let's delve deeper into the treatment strategies for acute pancreatitis. We've talked about the foundational supportive care measures, but what about treatments that specifically target the underlying causes?
As we discussed earlier, treatment is always tailored to the individual patient and the specific trigger for their acute pancreatitis. For gallstone pancreatitis, early cholecystectomy is often recommended.
So removing the gallbladder is the definitive solution for preventing future attacks?
In most cases, yes.
Okay.
By removing the gallbladder, you eliminate the source of the gallstones, reducing the risk of recurrent episodes of pancreatitis.
Now, what about hypertriglyceridemia-induced pancreatitis? How do you manage those cases?
The focus there is on lowering triglyceride levels. This often involves a combination of dietary changes, medication, and in severe cases, a procedure called plasmapheresis.
What is plasmapheresis and how does it work?
Plasmapheresis is essentially a blood filtering process.
Okay.
It involves removing the patient's blood, separating the plasma, which contains the triglycerides, and then returning the blood cells to the patient. The removed plasma is then replaced with either donor plasma or a protein solution.
So you're essentially removing the excess triglycerides from the bloodstream.
Exactly. It's like dialysis for triglycerides. Plasmapheresis can be very effective in rapidly lowering triglyceride levels and improving symptoms.
Now, what about cases where a medication is the culprit?
The first step is to stop the offending medication. Sometimes that's all it takes for the pancreatitis to resolve.
So identifying and addressing those drug-induced cases is crucial. Now let's talk about those potentially life-threatening complications, particularly infected pancreatic necrosis. We've touched on it briefly, but can you walk us through the management of this serious complication?
Infected pancreatic necrosis is a complex and challenging condition that requires a multidisciplinary approach. We typically involve gastroenterologists, surgeons, and interventional radiologists.
So there's a team effort to manage these cases effectively.
Absolutely. Treatment typically involves intravenous antibiotics to combat the infection. We also often need to drain the infected fluid collections to prevent further spread and complications.
You mentioned earlier that you try to use minimally invasive techniques for drainage whenever possible.
Yes. Minimally invasive techniques are generally preferred because they're less traumatic and lead to faster recovery.
Right.
Percutaneous drainage, where a needle is inserted through the skin into the fluid collection, is often the first-line approach. If that's not feasible or effective, we might use endoscopic drainage, where a scope is inserted through the mouth or nose to access and drain the collection.
And if those minimally invasive techniques aren't successful?
In some cases, open surgery might be necessary to remove the infected tissue, but we always try to exhaust less invasive options first.
So it's a stepwise approach, starting with the least invasive techniques and escalating only if needed.
Exactly. Our goal is to provide the most effective treatment while minimizing the risk of complications.
Now, beyond the acute phase, What are the long-term considerations for patients who have had an episode of acute pancreatitis?
As we've discussed, the risk of recurrent episodes is a major concern. We need to work closely with patients to identify and address any underlying causes, whether it's gallstones, alcohol abuse, or medications. Lifestyle modifications, such as maintaining a healthy weight, avoiding alcohol, and eating a balanced diet, are crucial for preventing future attacks.
So it's about empowering patients to take an active role in managing their condition and reducing their risk. Now, before we wrap up, I'm curious about the latest research in acute pancreatitis. Are there any exciting new developments on the horizon?
There are always new frontiers in medicine, and acute pancreatitis is no exception. Researchers are investigating new drugs that target specific inflammatory pathways involved in acute pancreatitis. The goal is to develop treatments that can not only control symptoms, but also halt or even reverse the damage to the pancreas.
So moving beyond just managing the symptoms to actually addressing the root of the problem.
Exactly. We're also seeing promising advances in the development of biomarkers that can more accurately diagnose pancreatitis, predict its severity, and guide treatment decisions.
It sounds like the future of acute pancreatitis management is moving towards more personalized and targeted therapies.
That's the direction we're headed. And with ongoing research and innovation, we're optimistic about improving outcomes for patients with this challenging condition.
It's encouraging to hear about those advancements.
Yeah.
Seems like we've covered a vast amount of information in this deep dive, from the basic science to the latest advances in treatment and research. But before we conclude, I want to leave our listeners with a final thought to ponder.
A parting shot to spark further curiosity and exploration. I like it.
So here's the question. Given the rising global incidence of acute pancreatitis and the significant impact this condition has on healthcare systems and patients' lives, what steps can we take as a society to raise awareness, promote prevention strategies, and improve access to timely and effective care?
That's a great question. It really highlights the need for, I think, a multi-pronged approach.
So where do we even begin with that?
I think a good starting point is public awareness.
Yeah, because so many people don't even know what acute pancreatitis is, let alone the risk factors.
Exactly. We need to educate the public about the signs and symptoms, the potential causes, and the importance of seeking prompt medical attention.
And early detection is key, right?
Oh, absolutely.
The sooner we catch it,
Yes.
the better the chances of a good outcome.
Absolutely. Delaying treatment can lead to more severe complications and a longer recovery period.
So public awareness campaigns could really make a difference.
Definitely. And we also need to focus on prevention.
Like addressing those lifestyle factors we talked about earlier.
Right. Things like reducing alcohol consumption, maintaining a healthy weight, and managing conditions like hypertriglyceridemia.
So it's about empowering individuals to take control of their health.
Exactly. And on a broader level, we need to advocate for policies that promote healthier choices.
Like what kind of policies are we talking about?
Things like taxes on sugary drinks, restrictions on alcohol advertising, and access to affordable, healthy food options.
So creating an environment that supports well-being.
Precisely. And of course, we can't forget about improving access to health care.
Especially for those who are underserved or face barriers to care.
Right. We need to ensure that everyone has access to timely and effective treatment for acute pancreatitis, regardless of their socioeconomic status or geographic location.
So it's about addressing those health disparities and ensuring that quality care is available to all.
Exactly. It's a complex issue, but I'm optimistic that by working together, we can make a real difference in the lives of those affected by acute pancreatitis.
Well, I think we've successfully navigated the depths of this challenging condition today.
We did.
Covering everything from the basic science to the latest advances in treatment and research.
It's been a fascinating journey exploring the intricacies of the pancreas and the devastating impact of acute pancreatitis.
We've learned about the causes, the symptoms, the diagnostic tools, and the treatment strategies that are changing the landscape of this condition.
And we've highlighted the importance of early recognition, supportive care, and addressing those underlying triggers.
If there's one thing our listeners take away from this deep dive, it's this. Acute pancreatitis is a serious condition, but with awareness, early intervention, and ongoing research, we can improve outcomes and potentially save lives.
So if you experience sudden severe abdominal pain, don't hesitate to seek medical attention. It could be a sign of acute pancreatitis, and early diagnosis is crucial.
And for those of you in the medical field, keep pushing the boundaries of knowledge. Keep advocating for your patients, and keep striving to deliver the best possible care.
Because together, we can make a difference in the fight against this formidable foe.
And remember, if you're hungry for more in-depth discussions on critical care topics, make sure to subscribe to Emergency Room Podcast. We'll see you in the next episode.
Thanks so much for joining us today on the Emergency Room podcast. Please smash that like button. It helps us reach more colleagues and keep the educational content coming. Don't forget to share this video with your fellow healthcare professionals. And if you're not already part of our community, please subscribe to the channel and hit the bell notification so you never miss out on our next cutting-edge discussion. We're dedicated to providing the most up-to-date, evidence-based information to keep you at the forefront of emergency medicine and critical care.